I have no financial disclosures. So radiology, the field of radiology, the invention of the X-ray tube has changed medicine, the practice of medicine, so much and over the last century that it's hard to fathom all the improvements in medicine that were made with the help of radiation. But it's also important to be respectable of radiation when you're working with your patients so that you can protect your patients from radiation injuries and also your staff, your colleagues, and yourself from injuries from radiation exposure. Over the last decade, the radiology communities have pushed forward these two slogans for interventional radiology procedure: image wisely for adults, meaning reduce the amount of radiation exposure as much as possible, and image gently for the pediatric population that we treat. So what I'd like to do is show you how you can use radiation reducing measures for your patient to prevent them from tissue injury, dose reducing procedures for yourself, and also dose reducing procedures for your coworkers. And these include the nurses, technologists, and the anesthesiologists that are in close proximity to the patient while you are performing the interventional radiology procedure. So let's start off with your patient. Just 2 weeks ago in Tanzania, the first TIPS procedure was performed, and this was a huge milestone for the practice of interventional radiology in Tanzania. I wish I was present for it. And TIPS procedures are very complicated. Here's a graphic showing what exactly happens during a TIPS procedure. Access is gained from the right internal jugular vein, and the hepatic vein, the middle hepatic vein, is connected to the right portal vein. The tract is dilated up to 8 or 10 millimeters, and a stent is placed so that portal blood flow can move through the shunt into the hepatic vein and back to the heart. And the whole goal of this procedure is to reduce portal hypertension, to reduce the chance of ascites formation and esophageal bleeding. It's a great case, but it's a very complex case. It can take hours to perform, particularly if the people performing the TIPS procedure are new to interventional radiology. So this procedure can last hours and hours. I'm going to show you a case that was published in 2019 and published in Diagnostic and Interventional Imaging Journal. This is a patient who had a TIPS 10 days prior, and she comes back to the clinic complaining of some itchiness and a strange sensation in the back of her abdomen. At 3 weeks, she comes back to see the radiologist, and there's erythematous papules forming on her back here, as you can see, that were not seen previously. At 4 weeks, there is starting to form a rectangular pattern of erythema on the patient's back. And if you look in retrospect at 3 weeks, you probably could see it form back there as well, this rectangular shape of erythema on the patient's back. At 6 weeks, the patient comes to be seen in follow-up, and wet desquamation is starting to occur on the skin. Now, if this happens to you, it's best to get the input of dermatology, have the patient see a dermatologist to find out what the best management for this patient is. So aggressive dermatologic input was requested for this patient. They started treating the patient's skin, and at 8 weeks, things were looking better. At 12 weeks, good healing is occurring. At 16 weeks, more healing. And the last image that was shown in this publication was at 28 weeks. So this patient sustained significant tissue injury during the TIPS procedure that was done for this patient. I'd like to show you another case published in 2001. This is a cardiology case. As you know, cardiologists, when they do the procedures, those procedures are long, and the patient gets a lot of radiation exposure. This patient is 57 years old, underwent percutaneous coronary angioplasty and stent placement. The patient underwent two procedures, 245 minutes of fluoroscopy, 2,000 frames of cine angiography. And in follow-up, you can see where the collimation was here with the radiation exposure to the patient's chest. And you can see this area of deep tissue injury here where an ulcer is forming. So this patient, because of the extent of injury, had to be seen by the plastic surgeons, and they did a skin repair to that site surgically. Another cardiology case I'd like to show you is from 2001. And this is a patient who underwent an EP study, electrophysiologic study in the cardiac cath lab. And this was radiofrequency cardiac catheter ablation for supraventricular tachycardia. The patient was seen 3 weeks after the procedure. A lot of erythema was forming at the elbow and just above the elbow. At 5 months, there was extensive tissue necrosis, and at 6.5 months, there is bone visible in the elbow joint. So the big question we have to ask ourselves is how can we minimize the risk of radiation-induced tissue injury for our patients? And that's my goal today, to walk you through some clinical things you can do in the interventional radiology suite to give the patient the lowest dose possible and to give yourself and your colleagues the minimal amount of tissue of radiation exposure during these sometimes long cases. So when I walk in the room, I'm ready to start a case. I am ready for battle. And I borrowed this picture from a book by Dr. Alex Capers. This is my mindset. I know the patient's going to have sometimes a long procedure. I want to minimize the dose of radiation for that patient. I want to make sure that myself and my staff are protected from radiation exposure during this case. And since we are working with trainees at our hospital, I want to make sure that they are well versed in radiation exposure and steps to take to minimize radiation exposure for the patient. And all the time in my mind throughout these cases, I'm thinking about all the steps that we have to do to minimize radiation exposure for the patient and everyone else. We're going to raise the table. We're going to spread out the skin dose of radiation. We're going to use pulsed fluoroscopy, last image hold, last fluoroscopy hold, minimize the use of magnification, and reduce the angiography frames per second and collimate. So that's a lot of information to take in on that one slide. So I'm going to walk you through these steps over the next several minutes. Raise the table. This is very important. You want to bring the patient up as high as possible, close to the image intensifier and away from the radiation source. And this is a graphic here that explains the importance of doing that. So on the right side of the screen here, where the patient's 60 centimeters away from the image intensifier, they're very close to the radiation source. Compare that with the image where the patient is 20 centimeters away from the image intensifier and far away from the source of radiation. In this situation, the patient is getting one dose unit of radiation exposure, with the patient close to the radiation source, far away from the image intensifier. The patient gets 4 times as much radiation dose to their body during that case. So raise the table up. The other thing we're going to do is we're going to spread the dose of radiation out on the tissues on the posterior aspect of the patient. Why did this patient sustain this amount of injury during a TIPS procedure? The answer is simple. The operators most likely kept the tower, the C-arm, in one position, one obliquity, okay, during the whole case. During the TIPS procedure, In the AP position, this patient got all of the radiation dose to one part of their posterior aspect of their body, right here, during the whole case. What you want to do in these long procedures is rotate the beam in different angulations, LAO, RAO, to reduce, to sort of spread out that radiation dose along the posterior aspect of their body wall, to reduce the chance that they're going to come to you in clinic weeks later with a radiation injury. So we're spreading the dose across the posterior aspect of the patient's body. Now, the obliquities on your C-arm don't just go from the left to right. They also go cranial and caudal. So during these long cases, you can also rotate the tower toward the head, rotate the tower toward the feet to further spread out the dose in a craniocaudal direction. So during the long cases, you're going to use the AP projection, the LAO projection, RAO projection, craniocaudal, caudocranial, and during all these maneuvers, we're going to spread the dose out on the posterior aspect of the patient's body so that the patient doesn't come back weeks later complaining of problems on the tissue, on the skin of their posterior chest and posterior abdominal wall. The other thing we're going to do during our cases is minimize the use of image magnification. You know, I would love to do cases with our image magnified during the whole case to see, you know, close-ups of our catheter, close-ups of the artery, the vein, the biliary tree, the renal collecting system, but that comes with a price. These patients with magnification are going to undergo more radiation exposure with that magnification. So we're going to minimize the use of magnification, don't use it at all if possible, and instead just bring the monitors close to the patient's table so you can get a close-up view of the screen during the procedure without the need for image magnification. So without image magnification, you get one radiation dose, 1 unit of radiation exposure. You increase it one time, you get more radiation. Increase to twice the amount of magnification, you get even more dose of radiation exposure. Here's a nice bar graph to show that. The entrance skin dose with the 23 centimeter field of view is at 100 units. You magnify once, you get 2.4 times that radiation dose. You set the magnification to twice the amount, and you get 4.4 times the radiation dose. On this other graph, if you look at the dose rate in microgray per minute, you can see that with a large field of view, you get a lot of radiation exposure. And when you reduce that, when you increase the field diameter, you get markedly decreased amount of radiation exposure to the patient and to the people present in the room during that case. The other thing that I notice people are hesitant to do is collimate. It's really important to collimate. There's no reason for the patient's entire abdomen to be exposed to radiation when you're working on, for example, the portal vein or the biliary tree. You're going to collimate to the field of interest and not expose the rest of the patient's body to radiation. It's a simple one step. It takes 1 second to do this. Collimate. It sharpens your image because of less scatter, and it reduces radiation exposure for the patient. This graph here shows that when you maximally collimate, you can significantly reduce the time of your procedure from 22 minutes to 13 minutes, 39% reduction. You reduce the radiation dose by 60%, and you reduce the dose rate of exposure by 23%. All significant changes when you just simply collimate during this case. Another thing you should do during all of your IR cases is use pulsed fluoroscopy. Pulsed fluoroscopy is available on all of the newer equipment. It's there. Make sure you use it. Make sure your technologists know about it. Pulse fluoroscopy is simply the creation of bursts of radiation, giving you a video clip rather than continuous radiation exposure. And here's a little illustration to prove what's happening here. With continuous fluoroscopy, continuous radiation exposure, the patient and yourself, you both get a high dose of radiation. If you simply use pulsed fluoroscopy, already you're reducing that dose by half. If you use more pulse fluoroscopy, use less frames per second during your fluoroscopy, you're reducing that dose rate even more. And if you're using even less, the lowest amount of frame rates as possible during pulse fluoroscopy, you get a marked decrease in radiation exposure to yourself and to the patient. So use pulse fluoroscopy. And I like to show this example here. If you look at this cartoon from the Walt Disney Studios, um, on these three pictures here, you have a rough idea of what's going on here in this video clip, but it's very choppy, okay? 2 frames per second. It's not very detailed. You sort of know what's going on, but it's not the greatest video clip. When you go from 2 frames per second to 4 frames per second, you sort of get more information about what's going on here in this video clip. And when you increase the frame rate even more to 6 frames per second, now you have sort of a full picture of what's happening in this video clip. So if you make an analogy to your fluoro cases in interventional radiology, you can tell by my example here that the more frames per second during pulsed frame fluoroscopy, the more frames per second, the smoother your video is going to look, the more detailed your information is going to be. If you're just moving your catheter from the groin up to the abdomen, you don't need a lot of detail. You can use a very low frame rate of pulse fluoroscopy. Once you're doing your actual embolization or implants or plug placement, or when you really need that fine detail to minimize the chance of complication during your procedure, that's when you're going to increase that pulsed fluoroscopy frame rate. But keep this in mind during your cases. You want to take as much advantage of pulse frame fluoroscopy as possible. And this graphic shows how much the radiation dose can be reduced by using pulse fluoroscopy. These first 2 bars show continuous radiation or 30 frames per second using pulsed fluoroscopy, and you're getting 100% of the radiation dose. If you reduce this to 15 frames per second, you're getting half the dose of radiation. If you reduce it further to 7.5 frames per second, now you're getting 30% of that radiation dose exposure. If you go to 3 pulses per second, now you're at about 10% of that radiation dose that the patient's body experiences. If you're going to do arteriograms or venograms using digital subtraction angiography, you're also going to reduce your frame rate during those angiographic runs. So on a typical abdominal arteriogram in our department, we use 3 frames per second, and they're very detailed. If I'm doing a patient, if I'm doing a workup for a pulmonary arteriovenous malformation, and it's vital to know which little arterial feeder goes to this malformation. Is there one or are there multiple feeders? If I want to get detailed information about those feeders, I'm going to increase my frame rate to 6 frames per second or more, but not for the whole case. Okay, just for those key points in the procedure where a high frame rate's necessary. So during your cases, if you're going to do arteriograms, venograms, reduce the frame rate. And again, looking at this cartoon, reducing the angiogram frame rate doesn't give you as much detail, but you're going to minimize the frame rate as much as possible. The other thing is, you don't have to do a lot of arteriograms or venograms. before you make the decision to take an arteriogram or venogram, just, in your mind go over, do we really have to do this? Can I do this case successfully without doing all these arteriograms and venograms? So you want to reduce the number of those that you actually perform during the case. Modern equipment in the IR suite also has the last image hold feature. So you're looking at fluoroscopy. You're going to think about your next step. You don't have to keep fluoroing to think what your next step is going to be. You're going to take your foot off of the fluoro pedal. Your last image will remain up there. You're going to look at that last image and plan your next move. This is very important for reducing image exposure to the patient and to yourself. Another feature on more modern equipment is last fluoro hold. The equipment saves the last several seconds of fluoroscopy for you. So you take your foot off of the fluoro pedal, you can review those last several seconds of your fluoroscopy during the case without giving the patient more radiation exposure. And when you look at that fluoro loop, you're going to contemplate the fluoro loop and plan the next move on your case. Also, when you step into the room and you scrub in and you put on the gown and your gloves to do a case, look at the settings on the table. Look at what the pulsed fluoro rate is. Look at what the magnification rate is, because the technologist may have set the default settings high with unnecessary radiation exposure to the patient, or the team that was using that room before you walked in the room may have the settings on high dose, high magnification, high pulsed fluoroscopy rate that you don't want to use, and you're going to make those changes in those settings. If you are seeing a patient with a body mass that is high, if they're obese, you're going to see that patient before the procedure and explain to them, look, you have a large amount of tissue that we have to penetrate during this case. We may not be getting all the detail during our case that we want to do to make this safe as possible for you and to make it a successful procedure. We may have to increase the radiation dose for us to see the structures. Because of your body habitus, this radiation exposure, because it's going to be higher, when we see you weeks after the procedure, we may see a rash on the back of your body. We're going to follow you closely to make sure no tissue injury occurs. If tissue injury is present and visible, we're going to get dermatology's assistance and provide the best care possible for you. All right, so we talked about how to reduce radiation exposure and tissue injury to the patient. Now let's totally switch gears and talk about reducing radiation exposure to you as the radiologist and to your coworkers, okay, your assistants, other residents, interns, fellows, anesthesiologists, nurses, technologists present in the room during the case. Well, there are three key things to remember here. You want to reduce the time of the exposure, you want to get away from the beam as far as possible, and you want to use shielding. Three simple things to keep in mind: time, distance, shielding. Time, distance, shielding. So let's talk about time. You want to minimize the time pressing the fluoroscopy foot pedal. This might seem like an easy thing to remember, but when things are getting very complicated during these cases, like for example the TIPS procedure, it's easy to forget that your foot is on the pedal and the patient's getting radiated and everyone in the room's getting exposed. So you want to get your foot off the pedal when it's not necessary. And I see people in our room when they're not even looking at the monitors, their foot is on the pedal and the patient's getting exposed. They may be turning away from the patient's table, reaching on the table for their next instrument, and their foot's still on the pedal. These seconds of radiation exposure and minutes all add up, and you increase the likelihood of tissue injury and exposure to everyone in the room just because your foot is remaining on the pedal. So take your foot off the pedal if you're not looking at the screen. Also, to reduce exposure to yourself and everybody in the room, turn the fluoro off. The last image will stay on the screen. You can contemplate what you're seeing on the last image and plan your next move for your case. And just as I said earlier, you can use the last fluoro during your cases. You're going to review that last fluoro loop and plan on the next move for your procedure. Also, keep in mind that if you have to collimate during your case, you don't have to have fluoroscopy being active during your collimation. You simply stop using fluoro, the last image will remain up there, and you can use what's called graphical collimation to close your collimators for the rest of the case. And as I said earlier, when we were talking about reducing dose to the patient, in protecting yourself and everyone in the room, you're going to reduce the fluoro pulse rate, the number of frames per second. You're going to reduce the frame rate during your arteriograms and your venograms to reduce the radiation exposure to you and the people in the room. And you're going to reduce the number of arteriograms and venograms that you perform for the patient. Let's talk about distance. Radiation is dangerous, okay, to yourself and everyone in the room. You want to get as far away from the radiation source as possible. If you're not the primary operator, if you're not handing wires and catheters to the primary operator, get away from the radiation source. The inverse square law applies to this. This law states that the intensity of radiation varies inversely as the square of the distance from its source. Okay, so if you move twice as far away from the radiation source, you will get 1/4 of the radiation exposure during that case. It's a very important rule to remember when you're in radiology for the rest of your lives. Simply moving a few feet away from the radiation source markedly reduces your exposure. Likewise, if the technologist and nurse don't have to be close to the patient, get them far away as possible. Get anesthesia away from the patient as far as possible. So when you look at this graphic here, this person here is the primary operator. They're doing the case. They have to stand there for this particular case. This person is just an observer, yet look how close they are. They're right next to the radiation beam. They don't have to be there. If you're a resident or an intern or fellow just watching, don't stand next to the beam. This person and this person are closer to the foot of the table. It's a good place to be. Instead of this scenario, what you want to see during a case is this scenario where the primary operator remains next to the patient doing the catheter movements, the wire movement, the balloon dilatation, the stenting placement, the coiling. And these three other individuals who are not intimately involved with the procedure are moved far to the foot of the table. Now, you might be lucky enough in your room to have another set of monitors hanging from the ceiling. You can simply move those monitors close to the foot of the table so that these three people can see what's going on, okay? But this is the ideal scenario. If you're not involved intimately with the case, get away from the radiation source. The other thing you want to do is make use of long catheters. Some of our catheters are 260 centimeters long, particularly our microcatheters and our guide wires, okay? And sometimes I see our trainees using these long catheters and they're staying close to the radiation source with this catheter just coiled up on the table. That's totally not necessary. And they're not making use of the length of this catheter. If you're working with a really long catheter, go to the foot of the table, move the monitors down to the foot of the table, and make full use of this catheter length and get away from the radiation source. It's a very important thing to keep in mind. Another important tool is keep your hands out of the radiation beam. This picture is from 2017 in the Asian Spine Journal. Look at what we're seeing here. The operator's thumb, their index finger, their third digit, their fourth digit, even their fifth digit is all inside the radiation field. This is totally unnecessary, okay? And they're repositioning this needle here for a facet injection. What you want to do when you're positioning needles during your case is we call this step and check. Position your needle, turn the fluoro off, adjust your needle, turn the fluoroscopy on briefly, look at where your needle is, look at the change you made in your needle, turn your fluoroscopy off, make your adjustments to your needle, turn your fluoroscopy back on, see what change you made, if it was successful or not, turn the fluoro off, adjust the needle again. So this cycle, and this may take 10, 15, or 20 times that you're turning the fluoro off and on again with these needle adjustments, but this saves a tremendous amount of radiation to the patient and to your hands and to everyone else in the room. So keep that in mind. And also use ultrasound as much as possible, right? If you don't have to use fluoroscopy, don't use it. Use ultrasound, for example, for biliary access or for access to the renal collecting system. Shielding is also important. Since the 1950s, radiation equipment in the radiology departments all across the world have improved markedly in their quality control, okay, in the amount of radiation the patient gets and the operator gets. Nonetheless, it's still important to use shielding, okay? The simplest form of shielding is this apron here. These two Velcro straps take a little of the weight off your shoulders and displace it to your hips. This two-piece this two-piece lead shield here distributes the weight to your shoulders and to your hips pretty nicely. There's also a suspended lead protection that hangs from the ceiling, and it takes all of the weight off your hips and your shoulders during the case. And here's what it looks like. These suspended lead protection tools are expensive, but they're available to you. Also, to protect your eyes, use lead glasses with side shields, okay? This is important to reduce the chance of you developing cataracts sometime in your career because you chose to go into interventional radiology. Radiation-induced cataracts are different from cataracts that the general population experiences, people who are not exposed to radiation. Their cataracts begin here in the nucleus of the lens. If you're exposed to radiation like we are, the cataracts begin in the posterior wall of the lens. Lenticular opacities start forming back here, and you develop cataracts. So radiation-induced cataracts form from direct exposure from the beam or through scatter of radiation from your bony components of your skull. There's no threshold for when these cataracts start to form. There's a linear dose response for cataract forming for radiation exposed workers. So use lead glasses, use side shields as well on those glasses. Also, make use of hanging lead shields. Put these shields in front of the patient and the source of radiation to protect your eyes. These shields are available hanging from the ceiling or on rollers. You can move them in front of the patient and the x-ray beam also in that way. When you're working on a patient, there's a lot of scatter from the patient's body. And of course, most of the radiation is under the table where you get exposed. So it's important to position that hanging shield appropriately, put that in front of the patient, in front of the image intensifier, and lower down in front of the radiation source. Also use a table drape shield, okay? This is what they look like. In the interventional radiology suite, you're probably used to seeing them look like this shield here. Um, Oftentimes, I walk into a room and find that this table drape shield has been removed. In our department, it's removed if a case is done in the room that requires rotational angiography or cone beam CT. And sometimes the technologist forgets to replace it. So make sure before you begin a case that the table drape shield is in place to minimize the amount of radiation exposure to yourself and the other people in the room. Does the operator get the highest exposure with the C-arm in the LAO position or the RAO position? Okay, this is the board's question during the physics part of your boards. Now, the radiation source is coming from under the table right here, and this is the LAO position. You're standing over here, so it makes sense that with the tower in the LAO projection, you are going to get the most exposure during the case because the radiation source is down here. You swing that tower this way, you're standing here, you're going to get 2 to 3 times the dose as if you had the tower in the AP projection. This graph explains this really nicely. If the tower is in the AP projection, you get this amount of dose exposure here. With the tower in the RAO position, the dose decreases quite a bit, especially if it's a 30-degree projection. If the tower swings over to the LAO projection, look how much the radiation dose increases to the operator. It's 3 times as much as radiation as if it was in the RAO projection. If you're using shielding, appropriate shielding, that markedly reduces the amount of exposure in the LAO projection. But keep a mental note. If your tower is in the LAO projection, you will get a lot of radiation exposure. Sometimes it's necessary to do a very steep LAO projection. Keep in mind that if you use this cross-table lateral steep LAO projection, you're going to get a lot of radiation exposure. So try not to use it. Sometimes it's absolutely necessary, particularly if you're doing cardiology work in the cath lab. If you have to use a steep LAO projection or cross-table lateral fluoroscopy, as you see here, keep that shield between the beam and the patient on the table because you're going to minimize that amount of radiation exposure to yourself and the team by doing that simple step. Let's talk briefly about scatter. There is a lot of scatter from the patient during these procedures. As I said earlier in this talk, you want to minimize the distance between the image intensifier and the patient. If the patient is low and the tower is high here, there's a lot of scatter that you're experiencing during that case. Bring that patient up toward the image intensifier, minimize the gap between the image intensifier and the patient, and that will reduce the amount of scatter that you experience during your interventional radiology case. Okay, now that you know everything about radiation protection, I'm going to give you 5 test questions. Number 1, pulsed fluoroscopy reduces the radiation dose, but gives A, uninterpretable imaging, B, the patient an unusual sensation in the body part that's being imaged, C, choppy videos. So the answer to this question is C. When you use pulse fluoroscopy, your video is going to be choppy, okay? And it's going to get choppier if you reduce that rate even more during the case. But you have to choose yourself how much choppiness you will accept to be able to successfully accomplish your IR case. Question number 2, image magnification. A, increases the radiation dose. B, decreases the radiation dose. C, follows the inverse square law. This is another large question. And the answer to this question is A, image magnification increases the radiation dose to the patient and to yourself. 3, the operator receives the highest dose of radiation when the C-arm is in the RAO position, LAO position, or the AP position.
The answer is A.
And the answer is B, LAO position. In this case, the source, the beam, the radiation source is going to swing out right next to you, and you're going to get a lot of radiation exposure. Number 4, according to the inverse square law, the lowest radiation dose will be A, next to the C-arm, B, at the foot of the table, C, at the head of the table. And the answer is get away from the radiation source as far as possible. Number 5, collimation. A, sharpens the image. B, reduces the radiation dose. C, sharpens the image and reduces the radiation dose. We talked about this about maybe 15 minutes ago, and the answer is collimation sharpens the image and reduces the radiation dose. So it's sort of a win-win. So in conclusion, interventional radiologists use X-rays to provide essential care to their patients. Radiation safety measures are key to minimizing the risk of injury to the patient, to you, the radiologist, and to the staff. Image wisely and image gently. Thank you so much for your attention.
Thank you very much, Dr. Paul, for that beautiful.
You're welcome. If anybody has any questions, I'll be happy to answer them for you.
So I don't know if anybody has any questions after this lecture.
Okay, excellent. It was great seeing all of you today, and good luck. I'll see you next time. Bye.